Okay, are we live?
Not yet. One second. Okay, we're live.
Okay, thank you very much. And welcome to this Health Insurance and Pharmaceutical Subcommittee meeting. It's a virtual subcommittee meeting, so I ask your patience as we encounter any technological or streaming issues. Before we begin, I want to remind committee members that this briefing is being streamed on the Maryland General Assembly's YouTube channel. Subcommittee members will be muted during this briefing. When they have a question, they will type the word question in our chat box on the right side of their windows. I'll call on delegates to ask questions. So delegates, when I call your name, please wait a moment while Melissa unmutes your screen. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each individual panelist. Also, please keep your questions shorter than the expected answer. Today, the Health Insurance and Pharmaceutical Subcommittee will receive updates from the Maryland Health Benefit Exchange on three topics, actually: the Maryland Insurance Program, the Maryland Reinsurance Program, the Maryland Easy Enrollment Health Insurance Program, and the impact of COVID-19 on insurance enrollment. We will also receive an update from the Maryland Prescription Drug Affordability Board. And I expect that we're going to be hearing some good news today from both of our panels. In our first panel, we're going to hear from Joanna Fabian Marks, the Director of Policy and Plan Management at the Maryland Health Benefit Exchange. This presentation will be followed by a question and answer period. Keep in mind, the briefing is live on YouTube, and when you're unmuted to ask questions, make sure that your background noise is kept to a minimum, as the Zoom audio features are very sensitive. Immediately after the briefing concludes, a recording will be accessible on the Maryland General Assembly Legislature's YouTube channel, and all of the delegates will be sent that link so that you can distribute it. It's our goal to conclude this briefing by 4 o'clock. Any questions of the committee now? Okay, then Ms. Joanna Fabian Marks, when you're ready to start, please go ahead.
All right, opportunity to present to you today. As Delegate Cullison mentioned, I'm Johanna Fabian Marks, Director of Policy and Plan Management for the Maryland Health Benefit Exchange. And we can go to the next slide. And I'll be presenting today on the State Reinsurance Program, the Easy Enrollment Program, and COVID-19's impact on enrollment through the exchange. So first up is the Maryland State Reinsurance Program. Sometimes we refer to it as the SRP. And I thought I would start, and we can go to the next slide, with just some quick background to refresh everyone's memory. And before I get to the background here on this slide, I just wanted to provide a quick historical recap. So as you know, in 2018, the legislature passed, excuse me, and the governor signed legislation that directed the exchange to submit an ACA Section 1332 state innovation waiver to the U.S. Secretaries of Health and Human Services and Treasury to establish a state reinsurance program. The federal government approved the waiver that same year in 2018 for a 5-year period of 2019 to 2023, and the state reinsurance program was implemented for the 2019 calendar year. And then in conjunction with that legislation directing us to apply for the waiver, legislation was also provide initial state funding for the program. That was a state fee of 2.75% on health insurance premiums that replaced a federal fee of that same amount that Congress had suspended for a year. So the implementation of the state fee didn't result in a net increase to premiums. And then in 2019, a 1% assessment replaced that 2.75% assessment to continue to fund the reinsurance program through 2023. And then meanwhile, the federal assessment was repealed. Okay, so just wanted to refresh everyone's memory on the history there. And now to speak to this slide, I also wanted to provide a quick refresh on the mechanics of the waiver. Reinsurance is pretty simple. It reduces premiums in the individual market by reimbursing insurers for a portion of their claims according to parameters set by the exchange's board. Lower premiums reduce the federal government's costs to subsidize insurance for people below 400% of the federal poverty level. And then under the terms of the waiver, the federal government passes their savings back to the state to spend on the reinsurance program. So when we talk about federal pass-through funding, what we're talking about is those federal savings as a result of the reinsurance program that get sent back to Maryland and that we are able to spend to support the reinsurance program. And we can move to the next slide. Great. Individual markets premiums have continued to fall. We've really seen great success of the reinsurance program. Average premiums for 2021 are down more than 30% compared to 2018, the year before the program went into effect. On the left, you can see a table of average rate increases. You can see that they were increasing by double digits before the reinsurance program, so up through 2018. And then since the program went into effect in 2019, they've been falling by double digits each year. And cumulatively, that's more than 30% as of 2021. And on the right, you can see, still on that slide. On the right, you can see a graph comparing Maryland's average lowest cost bronze, silver, and gold premiums against national averages. So it's a little bit small, but hopefully you can see that in 2018, before implementation of the program, our bronze and silver premiums were just about equal to the national average. But in 2021, as we move forward in time, our lowest cost plans at each metal level are about 20 to 30% below US averages. And that's really thanks to the reinsurance program. And we can move to the next slide. So as we've seen enrollment, or as we've seen premiums fall, we've also seen enrollment stabilize and start to grow. The graph here shows individual market enrollment as of the end of open enrollment for each year. You can see that enrollment fell in 2017 and 2018 as premiums were climbing, but then enrollment started rising in 2019 and 2020 as the reinsurance program kicked in. And I don't have data on this referenced in this presentation, but I did want to mention that MHCC does an analysis of the average health of enrollees in the individual market and in the other insurance markets. And they are seeing that the average health of enrollees is improving, which is a sign that the reinsurance program is really serving its purpose. And as premiums are going down, it's drawing those healthy individuals back into the market. So this graph just shows enrollment as of the end of open enrollment, so it's a little bit dated. And what we're seeing this year, largely, unfortunately, due to the impact of COVID, is that enrollment has really been surging over the course of the year. So we'll cover that more later in the presentation, but just wanted to mention that we'll be getting to that. And we can move on to the next slide. Yes, so we're happy to say, as you all know, that a new carrier announced it's entering the market in May 2020. United announced that they're rejoining the individual market, and they're offering plans on Maryland Health Connection for this coming year in 2021. And that means 2021 will be the first year with an increase in the number of individual market carriers since 2015. So just another sign of how the reinsurance program is stabilizing the market and making it more attractive to insurers to participate in. And then just a few slides to provide a little bit more just background on the mechanics of the program. So as I had mentioned, the exchange board sets the parameters under which payments are made to carriers through the reinsurance program. And they have been consistent since the program was initially established in 2019. So under the program, we reimburse individual market insurers for 80% of their claims costs for any individual who has more than $20,000 in claims in a year, up to $250,000. So in that $20,000 to $250,000 window for each individual who falls within that, the reinsurance program covers 80% of an insurer's claims, which is, I think, makes it the most generous state reinsurance program in the country. And I think is part of the reason, that we've seen such great success. And we can move on to the next slide. Yes, and so then just some information here on the cost and funding of the program. Along the top, you can see the actual costs for 2019, and then what our most recent estimates are for what the cost of the program will be in 2020 forward. And they've come in lower than expected for 2019. So our actuals came in at about $353 million. And it takes, we don't find out what the actual cost was until the year end. So of course we don't have the full 2021 or 2020 cost information yet. We won't really know that finally until next spring, but we estimate that it'll be about $378 million. And you can see that it increases over time. Federal funding is shown on the on the row below that, and that's how much pass-through funding that we're getting for the program. So you can see that in 2019, we got slightly more than we expected than the program actually cost. And we anticipate more than the program will cost in 2020. And then the amounts past 2020 are our projections of what the federal government will pass through. But again, they notify us of that each year. So we don't know for sure what those future funding amounts will be. But we do anticipate that federal funding is going to be sufficient to cover the cost of the program out through the current end in 2023. Next slide. And then here's, I think the most interesting part is just these top boxes and where it says federal funding spent on individual claims payments to issuers. So this is the breakdown for 2019 of how much funding went to each insurer in the individual market. The first three are all subsidiaries of CareFirst. So you can see that about 260 or 270 million went to CareFirst, and then Kaiser received about 85 million. And we had about 20 million unspent in federal funding, and any unspent federal funding rolls forward under the terms of our waiver to a future year. So we'll have that 20 million in reserve for the 2020 year to put towards that. And we can move on to the next slide. And then I did want to let you guys know about our carrier accountability reports. These are a requirement in our state regulations for the reinsurance program. And this is a requirement that all carriers participating in the reinsurance program submit an annual report describing their work to manage the costs and utilization of enrollees whose claims were reimbursed under the program, and also to contain costs so enrollees do not exceed that $20,000 threshold where we start covering a portion of those costs. So we do want to make sure that we continue this conversation with carriers and avoid a situation where anyone might feel that this reinsurance program is taking responsibility away from the carriers to continue to actively keep an eye on these high cost enrollees and work to keep them healthy and keep their claims controlled. So the report we're collecting for the first time this year, the reports were due at the end of October, and we're currently analyzing them and we'll be releasing them publicly. And we formatted the report to collect targeted information on diabetes, behavioral health, asthma, and pregnancy and childbirth, as well as general information on the most common and most costly diagnoses among enrollees getting claims reimbursed by the state reinsurance program. And we selected those conditions to align with existing state population health goals. And I think that's it for my presentation on the reinsurance program, but just want to say again how pleased we are with what we've seen in these first couple years of the program, and really, it's really had a very significant effect on stabilizing and improving the market. And I see there's a question there. I think I think my direction was that we would wait until the end of my presentation to take questions. So,
Yeah, we're going to go through all three parts of your presentation, and then, so save your question, Doug.
Okay, thank you. All right, so switching gears to easy enrollment, and we can go on to the next slide. So a little bit of background here first. Again, information that I'm sure you'll be familiar with, but sometimes helpful just to be reminded. We've got a graph here of Maryland's uninsured rate in green, so the middle line on the graph. And below that, you can see Massachusetts, which is the state with the lowest uninsured rate in the nation. And above that in blue, the US average uninsured rate. So you can see that we're historically and currently doing much better than the US average, but at a 6% uninsured rate, we're still about double Maryland or Massachusetts uninsured rate of 3%. So, still room for improvement. And the Easy Enrollment Program is one avenue to continue making progress in reducing that uninsured rate and making sure that people are aware of their options for coverage and making it easier for them to enroll. And we've seen that and just one other note is our uninsured rate has been pretty steady since about 2016 at about 6%. So we did see really great improvement in the early years after the ACA was passed, but we've hit a little bit of a plateau. So another reason that the Easy Enrollment Program is an exciting opportunity to try to make more of a dent in that. All right. And then a little bit more background on the uninsured in Maryland. And these are what we're calling pre-COVID numbers. So these are based on census data that was collected before the impact of COVID. So obviously these numbers are likely to have changed, but just using this data that we have as a snapshot, pre-COVID, the census estimated there were 357,000 uninsured individuals in Maryland. That's the 6% rate that I mentioned earlier. And about half of those folks we estimate are eligible for financial help. So that means they're either eligible for Medicaid or they're eligible to enroll in a plan through Maryland Health Connection with premium assistance from the federal government. And we've got a breakdown here in the graphic of showing how many of those are adults eligible for each type of coverage, and then how many are kids. And it's a little bit harder for us to predict what type of coverage kids would be eligible for, so they're just lumped into a group. And then we've got the other about half of folks who we estimate are not eligible for financial help. A portion of those is because their incomes are over 400% of the federal poverty level, which is the cutoff for premium assistance. And then the remainder are ineligible either due to their immigration status or because they have an offer of affordable coverage from their employer that they have chosen not to take up. But so we really want to get everyone covered, of course, but kind of the first group that we can focus on is these 180,000 who would be eligible for financial help and may not realize. And in fact, the exchange has done surveys that show about half of people who are eligible for financial help don't know that. So we can continue on to the next slide. So easy enrollment is a really exciting way to reach these folks who are eligible for coverage and may not realize it or may not have taken action to enroll previously. We're the first state in the nation to implement a program of this type. Colorado actually passed legislation this year modeled after what we did. And we've been fielding questions from other states that are also interested in copying Maryland. The legislation to establish it, as you'll recall, was signed by the governor in 2019 in May, and then we put in place some quick work to get this ready for the January 2020 tax filing season. So you can see an image here at the bottom of the slide of the state income tax return, and there's a portion of the return where you can check if you don't have healthcare coverage or if your spouse doesn't. And then on the dependents portion of the return, you can do the same also for your dependents. So you can check if you're uninsured, and then you can also check that box at the bottom to authorize the comptroller to send information from the tax return to us, the exchange, for the purposes of determining pre-eligibility. So what we did with that information this year is we determined whether someone was, in our consideration, eligible for a special enrollment period to get enrolled in coverage, because normally you can only enroll through the exchange if it's our annual open enrollment period, which is going on now, or if you have a qualifying life event, like you move, you get married, things like that. So if it's outside open enrollment and you don't have a qualifying life event, you're locked out of the market unless you're Medicaid eligible, in which case you can enroll at any time. But if you're not Medicaid eligible, you're locked out until the next open enrollment period. So what Easy Enrollment does is it creates a special enrollment opportunity specifically for uninsured folks who, what we call check the box, indicate they're uninsured, and have their information sent to us. So if they do that, this last year, we sent them a notice saying, you're eligible for this special enrollment period, come to our website and get enrolled. And then we followed up that notice with a postcard, and if they provided their email address with emails, again, encouraging them to come in, take advantage of that special enrollment period and get enrolled. Of course, it was an unusual year with COVID and taxes. So the tax filing deadline was extended to July 15th, and we extended the availability of the special enrollment opportunity under Easy Enrollment in alignment. So we had planned to wrap up the Easy Enrollment program in April, but instead continued that on to July due to the tax filing extension. And I think we can move on to the next slide. And so the results, what did we find from this? So we had about almost 61,000 individuals who quote unquote checked the box and had their information sent to the exchange. Of those, about 53,000 were deemed eligible for the enrollment opportunity. So we weeded out folks who we checked and saw that were already enrolled in Medicaid or a private plan through the exchange, or who were out of state, and those folks got a separate notice. But about 53,000 we deemed eligible. Of that, and we sent the notices, and then of that group, about 9,000 started applications with us. So that's about 17% of those who received notices saying they were eligible. And of that 9,000, about 4,000 ended up completing that application and enrolling in coverage. So that narrows down to about 8% of eligible individuals, which we think is really remarkable. You know, we'd like to see that higher, of course. That's a big drop off from 53,000 to 4,000. But for a relatively light intervention of just checking a box and then we sent them a letter, I think that's quite a successful conversion rate. So we have some additional information at the bottom of the slide here, broken down by various population types. So in the rows from top to bottom, we've got individuals who were deemed eligible, and then based on their household income, we determined they were likely eligible either for APTC, that's federal premium assistance for a private plan, or they were eligible for a private plan, but not with any assistance, that was the majority, or they were eligible for Medicaid or MCHIP, and that was kind of the second most at about 20,000. Then in the next column over, we've got the total enrolled, which you can see was highest for the Medicaid group, and we've got the conversion rate. So how many enrolled out of the number who were eligible. And we had higher conversion rates, unsurprisingly, for folks who are eligible for assistance. That would be Medicaid or APTC. We saw a pretty low conversion rate for people who were not eligible for any financial assistance. But I think it's really remarkable that there are 3,000 people out there who wanted Medicaid, took the action to enroll, and may just have been unaware that they were eligible or that Medicaid was an option for them. We also have a breakdown by age, and here we were really pleased to see, even though the numbers are relatively small on the individual market side, so that's the with APTC or unassisted buckets, the folks who enrolled in private plans. So even though overall numbers are small, it was effective in terms within that group of reaching young adults. So young adults ages 18 to 34 are a target population for the exchange because they're the most likely to be uninsured, and they're also healthier than average. So if we can get them in, it's good for the risk pool and it helps reduce premiums for everyone. And we saw that from those young adults of people who did ultimately enroll, the exchange targets a 30% enrollment rate for young adults, so this was exceeding our targets. And then we also have a breakdown by ethnicity. And here again, I think we were pleased to see in particular that the program seemed to be particularly effective at reaching Black Marylanders. So in terms of reaching populations that are traditionally more likely to be uninsured, including young adults and African Americans, we saw, that easy enrollment was successful in getting and bringing insurance to those populations. And we can go on to the next slide. So this was really just year one. So this, we're still in the beginning phases of implementing this. And I think what the real vision for easy enrollment was that we'd be able to get to some more expedited enrollment process. So what we were able to do, as I mentioned in phase one, was just to send the normal in the normal process that anyone would experience. We had been, I see I'm getting a message about my internet connection. Can folks hear me okay? Okay, I'm gonna take that for a yes. We had been hoping to move forward with an expedited enrollment process, and we were working with the Comptroller's Office and the Department of Health on how we might implement that, but we encountered some obstacles under federal law related to citizenship and income that would have required collecting some information that was really difficult to collect through the tax process. So we couldn't really effectively expedite enrollment without that information. And we were informed by our federal partners that there was no workaround to the collecting that information. So we kind of regrouped, and working with the Comptroller's Office and MDH, we came up with a new plan for phase two, what we're calling phase two, which is targeted for 2021, so a little over a year from now. And our vision for phase two is that we would pre-populate Maryland Health Connection applications using state income tax return data, so that when someone has that special enrollment period, comes to Maryland Health Connection to sign up for coverage, rather than having to complete an application from scratch, their application is largely completed using data from their tax return, and then they would have to go through and update or correct anything that might have changed and add a few more data elements that we can't collect from a tax return and then submit. But hopefully that would help improve that conversion rate by making the process easier for folks. That's it on easy enrollment. And then lastly, I'll be brief here, COVID-19 impact on enrollment, and we can move to the next slide. So We launched a special enrollment period in March. So that's another reason why it was a little bit of a weird year for easy enrollment to launch, is because right as easy enrollment was kind of getting going, we launched this special enrollment for any uninsured individual, regardless of whether they were filing their taxes, just because of the public health emergency. So someone could come to Maryland Health Connection and just indicate that they were uninsured, they were seeking insurance because of the public health emergency, and get coverage. So it's hard to say how that impacted easy enrollment, but I think it probably to some extent reduced the numbers that we saw this year. So that SEP, special enrollment period, opened in March. It's currently open through December 15th, and we've seen significant enrollment as a result of it. We've had more than 93,000 people enroll in coverage. 2/3 of those have gone on to be determined Medicaid eligible, and the remaining third have enrolled in private plans. And you can see on the graph on the right, in the blue line, we've got 2019 enrollment, and this is a standard trend line. We see our enrollment is highest at the beginning of the year, right after open enrollment, and then it declines over the course of the year. In green, we've got 2020. So this is quite a departure from what we typically see. We had that normal little decline from January to February. And then since then, enrollment has pretty well been trending up. And as of the end of October, our enrollment was about 18% over what it was last year. So we have seen quite significant enrollment growth in private coverage through the exchange. And then the next slide just provides, and this chart is a little bit hard to interpret, but there's two bars, one for each month side by side. And so we've got 2019 and then 2020 for each month. And the different colors indicate different special enrollment reasons, with the dark green being the COVID-19 special enrollment. So of course that only existed in 2020, not in 2019. So you can see in March, we enacted the special enrollment for COVID, and that's the first box on the left with the red outline around it. And you can see the arrow from the box to the left of it indicates the significant jump that we saw from 2019 in March compared to 2020. If we move over one set of bars to the right, again, the bar is outlined in red. You can see another big jump in April. And then you can see arrows going out through the rest of the year, kind of indicating how much special enrollments have been up, or in a couple instances, or one instance down compared to the previous year. So with the exception of May, we've seen some level of increase in special enrollments each month, but our really big surges were in those early months of the pandemic. But I think, just overall, we're really, this shows that the exchange is able to be flexible and accommodate unforeseen circumstances, and really provide that safety net for individuals who need insurance. And so we've been able to adapt and make sure that we're there and able to help out Marylanders who need to get coverage at this time. And that's it. So I know I covered a lot of material there, and I'm happy to take any questions.
Thank you very much, John. I appreciate all that information, and we do have some questions. So I'm going to go to Delegate Lewis Young first.
Thank you, Madam Chair. And thank you for the presentation. A lot of good information, but some of it was almost too good to be true. So I want to focus on something you said about the numbers to make sure I'm understanding it correctly. You mentioned that the state's cost to support this program would be reduced from 2019 from $326 million, and I'm rounding off, to $113 million. One of the charts showed that in 2021. That's a 63% reduction. Now, I know right up front you mentioned something about federal actions that would reduce our costs, but 213 million cost reduction seems like a lot, particularly in the midst of a physical and mental health pandemic, as well as increased enrollment. So given that our budget is financially challenged in 2021, I need to better understand the accuracy of this forecast and how it was derived.
Yeah, you're on mute, Joanna.
Thank you. I'm happy to take that question. If it's possible to pull up the slide, that might be a useful reference. It's the actual and projected cost slide in the reinsurance program portion. I think it's slide 9. But so I'll just it's coming up to mention that you're right. It is a very fortunate situation that Maryland is in, and you're not wrong about that with relation to the federal funding. In fact, what we're seeing is that federal funding is exceeding the cost that we're anticipating for the program. So I think you were probably looking at that state funding line. So you see that going down from 326 to 118. But let me just walk through this slide again briefly, because I know I covered it quickly and it's a lot of information. So the cost line at the top, that's how much we anticipate spending on our reimbursements to insurers. So that was about 352 in 2019, and the costs in out years are projections. And we work with an actuarial firm to collect information from insurers, and we work with the Maryland Insurance Administration to review that information and review the actuaries' assumptions. And then the actuaries provide us with those estimates. And we feel, pretty good about those. The further out you get in the future, the more uncertain they become. But I think, for example, the 2020 estimate is probably pretty solid. So that's how much we anticipate spending. The federal funding line below that is how much money we anticipate getting from the federal government in pass-through funding that we can then use to spend on the program. And we're actually anticipating that that federal funding is going to exceed the cost of the program in each year. Again, those are projections, and the further out we get from the current year, the more uncertain they become. But the 2019 and 2020 figures, there are actual amounts that we anticipate getting from the federal government. So we're looking at federal funding exceeding the cost of the program, and unspent federal funding rolls forward to be used by the state in future years. The state funding line below that is not what we anticipate the state spending on the program, because as I mentioned, we're anticipating federal funding will cover the cost of the program. The state funding is what we anticipate bringing in from that assessment that I mentioned. So the first year was much bigger because it was a 2.75% assessment. And then in 2020 and forward, it's a 1% assessment, which is why you see that number declining. However, we're not anticipating at this time needing to tap that state funding to fund the program, because we're looking at federal funding under current projections being sufficient to cover the cost of the program.
Thank you.
You're okay with that, Delegate Lewis? Yeah, okay. Delegate Krebs?
Yes, thank you. This was an excellent presentation, and I'm going to just stick to that slide that we were just on, and I think I'm catching on a little bit. But you mentioned the assessment, and just go back to the reinsurance program and the assessment. To the original 2.75% you said is going down to the 1%. I'm interested in two things. Number one, what is the impact monetarily on current rate payers that the assessment is on? And number two, this state funding. You said the state funding piece of it is the assessment. So there's no other dollars coming out of the budget. Is that correct?
That's correct.
So can you just explain what the actual impact is on other ratepayers? Yes. So because the assessment is a percent of premium, that's pretty easy to say. So in 2019, it was 2.75% of premium.
And in 2020 forward, it's 1% of premium. So that's increasing premium by that 1%. But I want to just kind of add that this 1% is kind of replacing a federal assessment of 2.75% that was repealed. So it's kind of, we're down 2.75 from the federal assessment, we're up 1% from the state assessment. So the net impact is premiums were not negatively affected by the state assessment, but but yes, it is a 1% assessment.
Okay, and then I just have one follow-up, if you don't mind, on the second part about easy enrollment. I think we've done some good things with the tax checkoff, and I really appreciate that, but I'm still concerned, what are the barriers for those people who are eligible for help that aren't getting it? Like even the Medicaid, it's free. So, and it's at only 15% of those eligible. What are the barriers for both the insurance and also for the?
Yeah, that's a great question. And that's something that we want to continue to explore. I think, the biggest barrier is just motivating anyone to take action. These people are getting a letter in the mail, and then they have to make sure, they have to open the letter, they have to understand it, they have to go to our website, and they have to complete the enrollment process. So, we across all ranges of human experience, whether it's enrolling in retirement accounts or other things that rationally are good for people to do, there's just inertia or blocks to them doing that. So I think that's why we want to look at how can we make that process easier so there's less friction for them. So it's just simpler for them to move from getting that notice that they're eligible to actually being enrolled.
No, and I thank you for that. I was thinking maybe it had to do with Medicaid, not exactly, but had to do with whether it's copays or plan type. But you just mentioned something that could be very easy. Is just getting on a computer and enrolling. It's not so simple for some people. So that's an interesting point that we need to look at, I guess. Thank you so much.
Thank you.
So I'm not seeing any other questions from the committee. Are there any other questions? I have a couple then. One is a comment. And I think part of the benefit that we're seeing in terms of premiums with respect to the reinsurance program is remember that what is not used rolls over to the next year. So we actually have had a surplus in each year. So we've been able to roll over funds, which, helps to mitigate the impact on payers. And Delegate Krebs, you asked a great question in terms of what the impact on payers is. The impact on them has actually gone down, which is what feeds largely into the premium reductions that we've seen, I think. So, I think that's why that program has been so successful and why we're looking in having a positive balance going forward. I had a question that follows up from Delegate Krebs around just bureaucratic barriers to enrollment. And do we currently, does the exchange currently have the capacity to follow up? So like for folks who began those applications, what kind of follow-up do we have? What kind of personal engagement are we able to have? And just, given staffing constrictions to see if we can't get more of them through the bureaucracy of the application process?
Yeah, that's a great question. And so we are able to follow up electronically. So we send follow-up emails if we have their emails, and we send a follow-up postcard. But we don't have the capacity or resources to do personal follow-up via, phone outreach or other kinds of personal outreach. And so, yeah, we're not able to do that with our current resource levels.
Yeah. And thank you for that. And the other question is, we were in a very unique year, and I hear, 93,000 people enrolled because essentially they could enroll all year. What impact, or are we learning anything from this that we might want to use post-COVID that will continue the rise in enrollments? You froze for a second, Joanna.
Yeah, that's a great question.
Yeah.
Oh, is,
There we go. Now we got you.
okay. It's a great question, and it's really a tricky one to answer because it's such an unusual year. I think we've definitely seen that there's a big appetite for enrollment. We've seen that most people enrolling are Medicaid eligible. So really, they didn't need the special enrollment period. They could have enrolled at any time, but I think a lot of people just don't realize that. So a lot of the benefit of this has been whatever publicity we've gotten from media. We haven't had the funds to do a large media campaign ourselves, but we've gotten a lot of coverage from newspapers and other sources. So I think one of the lessons is maybe just that making sure people are aware, whether that's through easy enrollment, whether that's through other, media channels, that they can enroll, really makes a difference.
Okay. All right. Thank you very much. I don't see any other questions from the subcommittee. So thank you, Joanna, for a wonderful presentation and very informative, and some good news. As Delegate Lewis Young said, some too good to believe, but it's true. So we're going to move to our second panel today. We're going to hear from Van Mitchell, who's the chair of the Prescription Drug Affordability Board, which is the first in the nation. So Van, tell us the good news. Oh, Melissa got to unmute. Van, you're on mute. Nope, still unmute.
There we go.
There we go.
Hi, everybody. Thank you very, very much for the opportunity to give you what I call as a brief report of the first year of operations with the Prescription Drug Affordability Board. And I think we've got a couple slides that we're going to show you. You can go to the next slide, please, Melissa. So as this committee is very well aware of, you passed HB 768, which set up the Prescription Drug Affordability Board, created to study the pharmaceutical market in Maryland and protect the state and its residents from the high cost of prescription drug products. The PDAB board, if you don't remember, is comprised of 5 members. You can flip to the next slide, please, Melissa. Those 5 members, I'll remind you, you set up in law of 768 that the board chair was to be named by both presiding officers, the speaker and the president of the House, and that's myself. Barry is from the Board of Pharmacy at University of Maryland. Jerry Anderson is from Johns Hopkins and is the Attorney General's appointee. Barry is the Speaker's appointee. Dr. Maloff is from Prince George's County. He's the appointment of the President of the Senate. And Joe Levy is also with Johns Hopkins, and he is appointed by the governor. We were actually 4 of us, other than Dr. Levy, were appointed in an August press conference, and then Dr. Levy was brought on board in December. Next slide. As those of you that have followed the board at the beginning, we started pre-COVID in January and February with meetings in Annapolis. I know the chair attended 1 or 2 of them. And then after that, we went into lockdown the same as everyone else did. We started with the help of the MHCC, which is our sister agency, the Maryland Healthcare Commission. And they helped us go virtual with a meeting in June. And then we set a schedule for meetings in September, October, and November. We've completed the 6 meetings this year in 2020. Seemed to go okay. And we stood up our website on July 1, which helped get the information out to people for transparency purposes. And we were able to put our meetings and our minutes online as well. We have set our schedule for 2021 as of last meeting. We will hold all of our meetings this year on the 4th Monday We were in conflict with the health exchange, unfortunately on the third Monday. So we moved it to the fourth Monday at 2 o'clock. So the January meeting will be January 25th. I had hoped that we would come back to Annapolis, but they've told me to stay away until at least April or May. So that gives you a snapshot. We will go every other month. So January, March, May, and so on through 2021. Next slide, please, Melissa. You'll recall in the 2020 short session that you had, we came to you with two requests. One was HB 1095 and SB 669, which many of you know is the funding formula that the board presented 2 years in advance of what the original bill called for to set up a permanent funding source outside of the state budget. We felt like we had a very, very good bill. We offered to pay back the money to MHCC. We offered to spread the cost instead of 30 or 40 companies to over 1,400 entities. And we capped the possibility of the revenue that could be raised at $2 million. We said going into it for the first 5 years, we figured we would be around $1 million. So we would hold the cost down to $750 per person or per PBM, insurance group, or pharmaceutical company. As you know, that bill was vetoed, passed significantly in both the House and the Senate. Governor vetoed it. HB 1100 was what I'd call a cleanup bill. It dealt with the number of meetings that we had to have. It dealt with the originally in the bill that you had passed, you had said the board should have outside counsel. I quite honestly believe that if this board's effective and we are sued, we will always use the AG's office to represent the state. So I didn't think it made a lot of sense for the board to hire outside counsel and then have to come back in and bring the AG's office up to speed. So we will be using a assistant attorney general as opposed to outside counsel. We still have the right to hire outside counsel, but I think this is a little wiser and more prudent from a financial standpoint. Technical changes, if you remember, you had 5 reports that were in the original bill. They were all due to report to you in December of this year. Obviously, because we hadn't at the time gotten a lot of things up, we asked you to move those back. They were moved back. This bill was passed and signed, and they were moved back to 2021. I will say that I'll probably be coming back to you. It might make sense to move a couple of these reports, not all of them, but maybe 1 or 2, back another 6 months or a year to make sure that we give you a report that makes sense and it has data. To collect these data for these particular reports, we budgeted $50,000 per report. So many of you know me from my background. I don't like to spend a lot of money if we don't have to. And so I want to make sure, I don't want to just give you 5 reports that really don't have any analytical or technical, support to them. So we'll continue to see that as we go through in 2021. The last bill was HB 1150. That was a bill that many of you might remember. It was a competitive bidding bill. What it did was allow the governor to go to DBM for pharmacy benefit managing, selecting. In New Jersey, if many of you remember in your test, there was a fellow that came down from New Jersey. They had passed it. And so we didn't see it as any harm to what we were going to be doing. And we thought actually it might have some positive benefits in a year or 2. And so we just thought it made sense. So we supported that from that standpoint. That was pretty much our legislative agenda last year, other than supporting, as you know, in the governor's budget was the $750,000 for our 2021 operating. So we supported that as well. Next slide. This is a quick little synopsis of the budget for us. So the PDAB currently exists, but we didn't have any operating funds with the bill. So we negotiated with the chief of staff when I got on board of the governor's office to either go through the HSCRC or the MHCC for funding for what we thought would be a year, year and a half until we got the funding bill passed and the funding stream up and running. As you can see, we did go through MHCC at their request. Ben Steffen and his staff have been tremendous, a lot of support to us and help. Our expenditures in 2020 were only $12,000, mostly made up of a individual under a contract to help me with some budget issues and things like that. The projected spending in 2021 will be including hopefully some staffing, contracting with some analytical firms that we have been in contact with, possibly or hopefully office space by then. So we hope that, I don't think we'll spend the $750 in the current year, but we'll certainly spend more than $12,000. We've completed our 5-year projected budget, which you had laid out in the original bill, and presented that to Department of Budget and Management. And as I said, we do anticipate those spending levels over the next 3 or 4 years to be around $1 million. Next slide. Staffing has been equally challenging, as you know, COVID, not a funding stream, and a hiring freeze. So it has been interesting this spring, but we got our MS-22 written for a couple positions, and we were able to get a contract person on board around the end of June, a young man that actually worked for the Maryland Health Exchange for a couple years, went to University of Chicago Law School, had just finished in May. So we brought him on board as a contract person, and he has been helping us with regulations and website and coordination with Department of Health and MHCC. We have been trying to reset our executive director position. We had it written back in January. We rewrote it. We received the pen in the governor's budget. We had to unfortunately resubmit it for reclassification because it was a wrong class. And then we had to get a clearance through Department of Budget and Management because of the hiring freeze. We finally got all of that straight, and we advertised it in October, as you see. I named a panel. The panel finished the interviewing process prior to Thanksgiving on the 20th. I then interviewed the last candidate, made them an offer. They have accepted, but we have 3 processes to go through now. We submitted the package to the MHCC because they're the sister agency. They just signed off on it yesterday. Then it has to go to the Maryland Department of Health. They have to sign off, and then it goes to Department of Budget and Management to obtain final approval. I have asked for a starting date of the end of the year, the 1st of January. So as soon as we know something from those 3 agencies and a total sign off, we'll be more than happy to send you a notice and announce who the executive director will be. Next slide. Some of this I've kind of already said, but I can't say enough. I've worked with most of these agencies in the past in multiple different ways, but Ben Steffen and Richard Proctor and their staff, whether it's with the virtual meetings or whether it's with HR issues or signing off on our requests As you can imagine, it's hard enough doing your own agency, but when you've got a new startup and you're trying to help them as well in the middle of COVID, I can't say enough for how they have reached out and tried to help us everywhere we can. You have to remember, I'm a non-state employee down here in La Plata with my office and Kathy McClure, who works for me. So we've been doing most of this and trying to coordinate it with Maryland Healthcare Commission, but they've really done a nice job. Next slide. Office space. So this has been interesting. I filed all the paperwork in February of 2020. Those of you that have ever been through this, you have to go through Department of General Services, DGS. We entered the description of the 4 roads that have to touch. You have to go through a quadrant where 4 roads connect, and we located that in the Bowie 5301 corridor. I thought it was easy for people to get to for meetings and different things, easy for staff to try to attract people from the Eastern Shore, Central Maryland, Southern Maryland as well. There has been several different setbacks. Mostly they don't necessarily want to go out, and I understand in COVID, to look at places. September, we were finally told that they had issued an RFP. No one responded to the RFP, which I found fascinating, with space that you would think would be available in these times. So anyway, last week, I did a site visit after talking to the deputy, and we did visit 2 locations in this area. One is move-in ready, and the other one would be a build out and would take me another 8 or 10 months. I told them my preference would be the move-in ready. So they are in the process of negotiating. It has to go through that. Then it goes to the Secretary of DGS, and then it goes to the Board of Public Works for sign off. So I hope that the executive director and the other staff who's working out of his basement will have some place to go to at some point in time, February or March. That too has been a longer than normal. Next slide. Those of you that have followed our meetings in June, you know that we decided to set up a little subcommittee. Because we're because we're a small board, which I absolutely like, it's a whole lot easier to not control, but I mean, to get to know people and to manage it better. But so we can only have two board members at a time meet. So our contract person and 2 board members have been meeting about where we go for your reports and for data collection and securing data and best practices and possible solutions and services. They have met and talked with different vendors around the country, a couple that we know here, like Hilltop, that does a lot of the Maryland Medicaid work, as you know, as well as others, a company in California. And so they're going to report back to us in January or February, their findings. They've also are having conversations with CRISP, HSCRC, and any of the entities within Maryland that we already feel like we already pay for and do things with, that we can possibly share the data and help reimburse them for the data instead of us paying 100% for the data. Like I said, the board and executive director will utilize the committee's findings and then inform later on the decision in regards to the acquisition and the analytical support. We have already received at our last meeting, we were very pleased to have CareFirst and Kaiser present to us. If any of you want to go on, the data is on our website. CareFirst did a very, very nice job. They had been working on this for a while in-house, and their CEO wanted to help us and support the board. And so they had a very nice presentation to the board at the last meeting. Next slide. Just some key takeaways. obviously stakeholders are eager to help. We've found that everywhere we've gone and been, that people, whether it's government entities within the state, outside the state, around the country, and individuals, whether it's CMS or CMMI, when we get our act together as far as our staff, they're all willing to help and support us. Like I was saying, Care First and Kaiser shared quite a bit of what they could share publicly in their drug costs and utilization. And we had a presentation last meeting from County Exec Glassman, who many of you know, and Barry and I have done a couple other functions with ARP and Vinny's coalition. Barry's really gotten passionate into this. He's drilled down on it. He's looked at his cost and what it affects Hartford County and what his high utilizers are. Not to take Barry's thunder, but he had about a 12% increase last year. He has a cost now of about $13 million, I think, and about 4 million of the 13 million is from, I believe he told me, around 80 employees. So he sees what the cost drivers are and what the effects of it have been. We've also, like I said, Barry has participated in several meetings. Jerry is doing one tomorrow night. So the board has been active, and whenever we've been called on to try to be out there, and whether it's with Delegate Pena-Melnick or Senator Feldman and others, we've tried to make sure that somebody from the board is on board as well. Next slide. You probably get a little bit of my frustration, and I normally don't think that I'm a frustrated person, but there have been obstacles and factors, obviously COVID, but I don't like to blame everything on COVID. But it has been tough getting office space. You can imagine it's hard to talk someone to come to work for you if you don't have a funding stream. You're asking that person to leave their job and their career. And that's a difficult sell job sometimes to be able to do. I hope we can get all that behind us. Data is going to be a problem. It is very frustrating, I think, to a couple of our board members. Jerry and Joe and Barry work in this field, both with Hopkins and University of Maryland, 365 days a year. They know some of the frustrations, and so it's good to have them on the board because I think we'll be able to, once we get our executive director on board, be able to cut through some of the red tape with some of the data quicker than usual. Public engagement has only been a factor, in my opinion, just because of COVID. I always enjoy having face-to-face meetings, as I know you all do as well, and that's been a frustrating thing. Going forward on the next slide, as I said, our next meeting is January 25th. It will be virtual. I hope some of you will tune in. We'll continue to work on the statutory mandates, the reports that are key, and we'll continue to work on relationships with our sister agencies. Obviously, new staff additions. My goal is to have the executive director on board in the first quarter, and possibly a analytical person on board in the second quarter. Let the executive director start to fill out their staff. As you know, we have pins at this point in time for five staff members. Public feedback and preparing for our stakeholder council, which you recall was in the original bill. The presiding officers are aware that they wanted to get, and I think this was a wise move, they wanted to get the board established, the operations of it up and running, the space, the needs, the staff, all of that done before they named the stakeholder council, because we really didn't have much to do at that point in time. And we have started promulgating our regs, which we would need to do if the funding bill goes through. And with that, my last slide is just questions. We do have limited staff, but we're always willing to talk and answer any questions. You see the website there, pdab.maryland.gov. It does have our meetings, it does have the minutes, and it does have any of the presentations that have been at the meeting so far. So please feel free to review it. And if there's comments, please feel free to get back to us.
Okay. Thank you very much, Van. This has been a tremendous presentation in terms of just telling us where you've been and where you're planning on going. Are there any questions from the committee for Van? Well, perhaps while you're thinking of one. Oh, I see Delegate Krebs. Delegate Krebs.
Thank you, Delegate Collison. Van, thank you. I know that's been frustrating and slow, but I know that the federal administration has been working, HHS has been working on prescription drug affordability for quite some time, and they've come out with some very detailed plans that I've gone over actually with Vinnie DeMarco a year ago. But how are you guys using, or are you using what the federal government is doing and piggybacking that onto your work, or not?
Sure.
Is it helpful?
Yeah, I think we're going to have a whole lot more to tell you after our executive director, when they get approved. We believe that we've had conversations with CMS and CMMI. We believe that there's probably as many as 18 or 19 items that the federal government over the last 3 or 4 years have worked on in a bipartisan position that are kind of low-hanging fruit that we would like to be able to roll out to you sometime in the next 8 or 9 months. And we feel like, from my understanding, talking to different people on both sides of the aisle in Washington, everybody's in pretty much full agreement on some of these items. So we think it's a great opportunity to get some steam going down the road, so to speak, and where there's bipartisan agreement and where there's agreement that, some of the pharmaceutical firms have already agreed to. So that would be our hope. Yeah.
I know, I appreciate that, because I think we're going to be a lot more successful if you can weigh in on those items, because the list is stuff we've been talking about for years. Like, one is surprise billing, which doesn't come under you, but when I look at the list, it's like, wow, this is what our committee's been talking about for a long time. And I would hope that this group would feel like they can weigh in on those things and help push these things over the line.
Yeah, I
more
think
momentum.
Yeah, I think if the chair is willing, we'd like to come back to you sometime in the early spring when we're ready and kind of roll that out for you to take a look at and kind of weigh in for us.
Thank you.
Well, if you're speaking to this chair, I know that I would be very interested in having you back. We talk with the subcommittee and the committee chair as well. I have a couple of questions in committee members think about if you have any other questions. One is, there are going to be a lot of competing budget needs in the FY22 budget, given what we're going through. But do you have a sense, given the fact that carriers are coming to the board and saying, this is an issue for them, that they would continue to support the assessment on them to fund the board the way it was passed in this past year? I think it was 1105 was the funding bill, or the 1095 was the funding bill.
Yeah, I sat in economic matters when we did the donut hole, and we assessed back then Blue Cross Blue Shield an assessment to pay the difference. When I talked to different carriers and told them it would be $750, they looked at me and smiled because they've never seen an assessment come out of us for that little. Back then it was $4 and $5 million, as you remember. And so I think as long as we are realistic with our ask and that we don't create a situation where it's going to cost them millions of dollars each, I think they will be very helpful. For them to spend $750 to invest in this entity, and it could return to everyone's benefit, not just a carrier, but everyone's benefit. It's a great return on investment. And so I have found, I don't want to speak for all of them, Chair, but I have found the majority of them that have reached out and I've talked to are very much interested in this.
Great, thanks. And the second question, I know that you are now really in setting up operational mode. So this may not have happened yet, but I'm wondering, what the plans are, or maybe it hasn't, I just don't know it. Attached to the board is the advisory committee. Have you had any engagement with the advisory committee? If so, how is that set up? Or if not, when do you anticipate engaging them in the issues?
So that's what I referred to as a stakeholder. Is that the same
Oh,
group
okay.
you're talking about, stakeholder group?
Right.
Yeah. I
Right,
think it's 26 or 28 members.
right.
We talked early on, or at least I had conversations with the presiding officers, and I felt it was and they were very supportive and actually brought it up to me at the beginning. I felt it was very important to get this board on a very sound footing financially and operationally.
Okay.
And it's hard to bring new people into state government and they not know all the ins and outs with whether it's personnel, a DBM, HR, DGS. You got to almost be in the state for 20 years before you have a feeling for that. And so I said it would be very hard for a board and 4 or 5 members to concentrate on a large group like the stakeholder group of 28 people, right? Mm-hmm. And do that at the same time. So I hope we made the right decision. We obviously got delayed because of COVID. We got delayed because of funding, but I think we're pretty well set. I mean, you have a 5-year budget. You have in my opinion, a very, everybody around the country that's talked to me about our funding bill mm-hmm. thinks it's great because it caps how much the board can raise. It pays back the state entity that lent it the money, and it spreads the cost instead of 30 or 40 companies to 1,400 companies. So, I think it's very fair, and not everybody has to pay a lot. So I think, long way of saying, I think we're going to be on extremely good foundation to where when the executive director gets on board, they're only going to have to worry about going forward. They're not going to have to worry about office space and people and reclassifications and pens and all. That's all done for them. And so I think at that point in time, this spring is when the presiding officers, they're the ones that collect the resumes and they're the ones that make the picks and the choices for that group. So I think, I don't want to put words in their mouth, but I would imagine that they'll probably move forward this spring.
Okay, great. I really appreciate that. And I appreciate
Sorry it was such a long answer.
I appreciate this strategic thinking behind it. So thank you for that. Are there any other questions from the committee? I just want to add that I had the opportunity to work with National Conference of State Legislatures work group this fall on containing drug costs, and the board was a big topic of discussion, and other areas are interested in looking at our legislation and considering how they might incorporate it. Of course, the general feeling of this work group was, boy, do we wish we had some federal support on this issue, but given that we can't, then, or we haven't had so far, we are, the states that were participating in this work group were looking at ways that varieties of states could get together on a single kind of program where they would be networking and helping each other, like the boards connect, like if there were boards in other states connecting. So there's great potential there, I think, and I look forward to you being fully operational when you can be. So with that, I want to thank. I'm
sorry, Delegate Collison. I think Delegate Saab has a question.
Oh, I'm sorry, Delegate Saab. I was busy chatting. Delegate Saab, would you go ahead with your question, please?
Yes, thank you, Madam Chairman. I just have a quick question. I may have missed it, and I know you sounded a little enthusiastic. I'm just curious about not necessarily the return on the investment that we're spending, but in your view, when would be the first time that we'll actually see some difference in savings when it comes to prescription drugs? And what is the saving compared to the money that we're spending on the board, which is $2 million a year?
Oh, I think the savings, we haven't put pen to paper, but let's say you end up in the next 2 or 3 years averaging a $750 to $1 million spend. I could conceivably say that you might see a return of $15 to $20 million a year on that in the out years. That's conservative.
Isn't this only
you know,
for
I
state
think
workers?
Yeah, our charge, I actually is for retirees and state employees, and county employees fall into that. So I think that's where we'll start to drill down with the help, of MACO and the carriers like United and Care First. Hopefully, we'll be able to help bring some quick relief to the marketplace. We're in a free market. So, and I used to sell lumber and plywood, those of you that don't know. And nothing's more of a commodity than lumber and plywood and gasoline. But I was always amazed at Georgia Pacific and Weyerhaeuser, and when things got tight and the competition got going, or a new new product came on the market, the traditional price dropped. So, Delegate, it's a long way of saying that this board gets organized and gets real active. It could just have a positive impact on the marketplace just by being here. Mm-hmm. Now that's hard to quantify at times, but we'll be able to quantify that going forward, I think. So I've always found that companies in a free market, they understand if they're about to lose part of their market share, they understand that they might need to change the way they do something. And so that could be positive as well.
Right, but they would do that on their own. They wouldn't need a board to tell them to do that.
That's correct. But the reason they would be doing it would be because of the board's actions. Mm-hmm. I'm just saying, as part of a positive that could come out of this, and I think it already has, to tell you the truth. It'd be interesting as you go forward in the session to see what the numbers that DBM are paying, see what the numbers the counties are seeing, the health exchange, HSCRC, the hospitals, all of it, will have an impact. So,
do you happen to have any, with your projections, to show us any like numbers or graphs or data, or is this just your feeling?
No, we don't have anything per se correctly now because we don't have any money to collect any data or buy data, and we don't have any staff. But I'm just saying, from my anecdotal standpoint of being in the free market standpoint all my life, pressures generally have a positive impact. Years ago, when I was on appropriations and we passed supplemental rebates, and then we allowed the state to go and Medicaid into a consortium of 28 other states, it all had a downward pressure on the price, right? So it gave us a better way of being able to price the drugs in Medicaid, and it gave us more of an opportunity to collect rebates on the price we were paying because of the volume. So all of those things help lower it from that standpoint.
So the saving goes, sorry, man, one quick follow-up question. So the saving is really more to the state and municipalities, but not directly to the end user, which is the member.
Well, our first charge was, I think, to state employees, retirees, and county employees that are in those plans. And then the second part of that was to report to you what we thought we could do in the open marketplace for Marylanders. But by and large, I would say that if we have an effect on a retired state trooper's cost that he or she pays, it's going to affect their whole family.
Right, but it's very minuscule, but I appreciate it. Thank you. Thank you.
And Delegate, I would just ask you, if you look at I see Delegate Morgan. If you look at the return on the reinsurance program, in terms of what it's done to rates, once we can get a handle on the issues of drug costs and where they're coming from and what's causing them to be so high, and you make the market kick in competitively, I think that benefit's going to go back to the members, the insurance members. So it's a long time, it's a process, but we're certainly on the way.
Right,
Delegate Morgan?
I'm sorry,
I'm
one
sorry.
quick follow-up. So, but yeah, I mean, I understand the comparison, but that's the reason with the raise was due to large amount of federal funding, not of, I don't think it's apples to apples. We're comparing apples to oranges, but I understand your point. I just don't think it's the same.
Okay.
Thank you.
All right, thank you. Delegate Morgan. Oh, where did he go? Delegate Morgan? Melissa, can you help me find it?
So his internet connection apparently went down.
Oh,
He's not in the chat anymore. I'm not sure able to text him.
okay. We'll give him a minute. And this is part of that first part of the introduction when we say, please be patient with our technical challenges. We're all learning here. Okay. Delegate Saab, is he in touch with you by text?
I just got a text from him, it says his internet went down.
Okay. Is he trying again?
I think so, yeah.
Okay.
Those of us in Southern Maryland have that problem quite often.
And the Baltimore County schools have that problem right now.
Well, they have a different problem.
Serious problem. I was speaking with someone earlier, and we all know what the issues of ransomware are, but it basically, because of their virtual learning, it knocked out education in Baltimore County. It's pretty challenging. Okay, Delegate Morgan sent me a text as well. I'm just going to ask him to try again. We'll be patient for another minute or so.
I can FaceTime him and put him on my camera.
We've also texted him from the committee side as well. So
Okay, he says he'll save his questions for another time. I'm sorry that happened, and
That's all right. He can always call me.
that's right. That's right. He knows where you're on his way home, so from Annapolis.
He knows where I am.
With that, any other questions from the committee? Then again, I want to thank the panelists, Van and Joanna, for your great presentations. And just tell the folks who are watching that as of now, HGO has scheduled a series of full committee and subcommittee briefings. For the public, please monitor the HGO committee hearing schedule on the Maryland General Assembly website for updates. For committee members, you've previously received a list of meetings and dates via an email from committee staff, and you'll continue to receive updates as necessary. The next meeting on our schedule will take place on Thursday, December 10th at 1 o'clock. On that date, the Public Health and Minority Health Disparities Subcommittee will receive updates from the Maryland Medical Cannabis Commission. So we look forward to seeing you there. Thank you all for coming today. I see Chairman Pendergrass.
Madam Chairman?
Yes.
Yeah, I think that we have scheduled another briefing, a joint briefing that day with, let's see, government operations. So there will be a joint meeting that day. Check the website and stay tuned because that's just happening today.
Okay, and that's December 10th at 1 o'clock.
Correct.
Right. Okay. Thank you very much, Madam Chair, for
Very
updating
welcome.
us. Let me
Bye-bye.
thanks. me just see, this was, oh, okay, never mind. It's Delegate Morgan saying, no, I can't try again. So thank you all for being here. We look forward to seeing you at the next meeting. Take care, everyone.
Thank you.